Good afternoon, and thanks for the Society for the opportunity to present our study. Being the general anesthesia, a standard practice to realize a VT, some questions may come up. Could the VT with local anesthesia and sedation be realized with safety and comfort for the patient? And how could the safety of this method be confirmed? The objectives of our study were to evaluate the feasibility, safety, and effectiveness of VT with local anesthesia and sedation, and to make sure if this combination could be a feasible choice. To evaluate the executability, we got the proportion of cases where the procedure has been executed as planned, and if the patient reports some memory of pain or discomfort as well. The safety was evaluated if the tracheal intubation was needed, if changes in vital signs put the patients at risk were detected, the necessity of post-op in ICU or deaths. On the other hand, the effectiveness was evaluated if the procedure reached its goal. The sedation standard was midazolam in the admission operating room. And the fentanyl infusion, this moment was considered as time zero in the study, and the patient was positioned. And then the propofol infusion starts. At this moment, the patient and advanced equipment were ready. After the beginning of propofol infusion starts, the local anesthesia of the camera port was performed 2% lidocaine. After the camera port has been introduced in the pleural cavity, the other port places were chosen, and the local anesthesia was performed. The values of O2 saturation, blood pressure, and heart rate were collected every 3 minutes, and then they were compared of the values at the time zero of the procedure. Furthermore, the values of O2 saturation and heart rate were obtained at the moment when the thorax has been introduced in the pleural cavity. And then the comparison with time zero was also performed. 20 patients were operated. 13 seniors and 10 patients with cardiovascular risk were found. The mean VT time was around 21 minutes. Any patient needed tracheal intubation, post-op in ICU or thoracotomy conversion. No one reported memory of pain. The VT proposals were reached in all VTs, and no deaths have occurred. The indications of VT were 18 different recurrent pleural effusions. 2 pneumothorax, kilothorax, mediastinal tumor diagnosis, enclosed chest trauma, 1 case each. Regarding the statistics, the O2 saturation, heart rate variation was not significant, even in seniors or cardiovascular risk patients. The blood pressure dropped with significant p-values, but no interference in perfusion occurred and no vasoactive drugs or volume were needed. And then no significant variations of the O2 saturation and heart rate were observed in thorax introduction moment. Concluding, the VT under local anesthesia sedation is feasible, safe, and efficient, and it was performed successfully, and the goal was reached in all patients operated. It can be used for different kinds of pleural cavity disease. The surgery is safe. There is no need for tracheal intubation, admittance in ICU, and all that occurred to any patient of the study. Thank you.